Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are again with Jason Jarvis. Jason is a former 18 Delta. He has his master's in infectious disease from the London School of Hygiene and Tropical Medicine, and he's currently working on his PhD in Trop Med. Jason, welcome back to the program.
Thanks, Aebhric. It's good to be back.
So tell us a bit about yourself and what is keeping you busy.
Well, you kind of hit all the nails on the head with that intro. So, yeah, I just finished my master's last year with University of London, and I'm currently in a PhD track with Widener University here in the States. And what's keeping me busy is I teach mainly American Heart Association courses throughout the Seattle area, mainly ACLS and PALS. While I'm working through the PhD, and then the other thing that's come up this year that both of us are working on is our 3rd edition field guide.
Yeah, that's a long time coming, and we had that for Christmas distribution. Is that right?
That is correct.
So, Jason, you and I have chewed the same dirt for many decades. We were in 3rd Special Forces Group together in the early 90s, and then after the Q course, we both happened to go to 1st Special Forces Group in Seattle, but you were lucky enough to go to 3rd Battalion, which was the hot weather battalion. So you went to Thailand, and battalion goes to Sri Lanka and India, all those cool places, and I got stuck in 2nd Battalion, cold weather battalion, where we invaded northern Canada in the wintertime and spent many deployments on the DMZ in Korea. But you had the fun place. How was that for you?
Well, yeah, it was the hot weather battalion. So 3rd Battalion, 1st Special Forces Group. So we actually got into Korea while I was there, but we were involved mainly in Thailand, and I also was able to get into Laos for a trip, which was a very interesting mission and a different story for a different time.
So tell us about your experiences being a Green Beret. How was that? How was being the tip of the spear?
Well, tip of the spear in the late 90s when I was most active with all this. You know, first group wasn't, I don't think any of the groups were that busy with real world missions. There was a lot of what we call foreign internal defense type missions, medcaps. So a lot of peacetime missions. I understand the 7th group guys were pretty busy down in South America, Central America. There was certainly, there's always real world stuff going on down there with those folks, as well as, 5th group over in the Middle East. They had some stuff going on, but I left the military right before 9/11. So all of a sudden, with 9/11, the whole everything changed. So you had SF groups that would have been otherwise just deploying to Europe or South America or Africa. Suddenly, everyone's going to the Middle East for the next 15 to 20 years. One of our mutual colleagues, Josh, who, if I'm not mistaken, was in 7th group, South America, Central America, and never actually deployed to that continent. I think he did all of his trips to the Middle East, at least while he was in.
Well, we did get to invade Haiti when we were in 3rd group. That was kind of fun.
Yes, there was Haiti. I went down there in '95 with 3rd group as a support guy. So I was in the weapons and ammunitions department at the head shed down there. So I got to wake up to little caches left by teams in the middle of the night in our hooch. So you'd wake up and there'd be, a box of grenades and a Uzi and various ammunition components and so forth. So, but Haiti was nice. It was that was one of my first times in the tropics, and perhaps that's where this whole thing started for me, just having a really acute interest in all things tropical.
And then after we both got out of 1st group, We went to community college, and we met there at North Seattle Community College, and then randomly in 2005, you had been working for DMI for a bit. I came in about 2005, 2006, working with Dr. John Hagman, who was one of the original creators of the TCCC concept. It was his research that based a lot of this on. And he started the Deployed Medicine International, where a bunch of us, was it 75 Green Berets at one time, were working for DMI. And then you and I met there again after all these years.
Yeah, that was a pretty impressive operation back in its day. I came on in '97 once I decided that 3 or 4 years in Iraq was enough. So I spent the next 8 years there, coming into the fold as a trainer, and learned learned so much along the way. And this DMI was the first time I had encountered prolonged field care as a concept, as far as a systematic way of approaching a patient in a prolonged field care setting. That had never been, to my recollection, that was not being taught in the schoolhouse. And I actually have a couple of references here I'd like to share if we have a minute for this.
Sure. Let's. This is from the OEMS, the Operational Emergency Medical Skills course that you and I taught for Hagman.
Yeah, and then going back even farther in time, so the reference you mentioned was Tactical Combat Casualty Care and Special Operations, which was published in '96 by Hagman and Frank Butler. So that came out in '96, and I went through my initial medical training in 1997 at Fort Bragg. And I actually happen to have a hard copy of one of my manuals from that course in '97, which is entitled "Nursing Subjects." And I'm just gonna read the table of contents if I can here, just so we can see, where the special operations community was in '97 with this versus 10 years later in 2007 when I first joined DMI. Where the principles of prolonged field care had been a little bit more codified by DMI. So this is from 1997. So this is the Phase 3 Nursing Subjects Manual, and there's table of contents talks about isolation precautions, postmortem care, post-trauma, post-operative nursing care, surgical dressing, basic casting, family planning, contraception, nutrition, deficiency diseases, assess blood replacement, wounds and wound healing, and then wound infection. So, looking at this just at the table of contents, really the only thing that looks like a one-to-one carryover into the future concepts of nursing and prolonged field care is the wound infection aspect here.
And we saw that at DMI with Hagman. Hagman came up with try AEIOU, and the wound care was part of that, wasn't it?
Yeah. So in like I said, in 2007, when I started working at DMI, having fully transitioned out of the military and doing the military private military contractor jobs that I was doing in the Middle East. So in 2007, this is when I first came across the nursing care. It wasn't even a nursing care mnemonic. This is just for prolonged field care at large or writ large. So it stands for tubes, record and reassess, infection, which was mainly looking at wound infection. And then you had the A was analgesia and anesthesia. E is environment, I is intake, O is output, as in stool and urine, and then the U was ulcers, as in decubitus ulcers. So there's a lot of nursing things within that. The environmental stuff, which is, you could classify that as both a medical and nursing care item as well. And yeah, that was kind of my introduction to prolonged field care as a systematic approach. This is the first time I had come across that.
And the Hereford lads had Hitman, and they got that from '05 or '06, I think. But they're it's a different way of addressing try AEIOU.
Yeah, and I was familiar at the time. So in the 2007 timeframe, I was familiar that the Hitman acronym Mnemonic was being used over in the UK. On the state side here, we had Ravine or Ravines. I forget the exact mnemonic, but that was being used, I guess, within the American military, and then DMI had kind of, I don't know, maybe borrowed from both of those systems and created this try AEIOU system.
Yeah, the ravines came from the Prolonged Field Care Working Group, which started in 2013, and and I saw them first. My first SOMA was 2014, when you and I met in Florida to do the pre-SOMA OEMS course with Hagman, and that SOMA 2014, there was kind of a larger group and discussion within SOMA on the origins of Prolonged Field Care Working Group.
Yeah, so it's interesting to see, here in the year 2025, how things have evolved in the last, I guess, 23 years, if my math is correct here, 25 years. Going from '97, where nursing care was basically, the things I just read off that list, right? It was a lot of, I don't know, I'm not sure why they put casting in that, but that's where the SF Schoolhouse put casting in their format there. So you had casting, and you had some other things that are certainly nursing skills, but not things that we would necessarily consider as far as, okay, we need to provide good nursing care to this casualty because we're stuck in the field for an extended period of time and we just can't get to a hospital. So since this patient isn't in the hospital with a nurse looking after them, then we have to be the nurse looking after them. Yeah, so if we go back 15, 20 years, we're looking at, I guess, three different prolonged field care mnemonics were in use that I was aware of. And the one we were teaching at DMI was the TRI AEIOU acronym. There was also Hitman, and there was Ravines, and then how this all kind of goes into the sheep vomit mnemonic was, one day in Malta at the Seabreeze Hotel, you and I just sat there sipping some tea, and we just kind of played Scrabble letters with all of these different all the different letters of the different acronyms. So the Hitman, the Ravines, and the other one. And I guess we were trying to come up with I guess you call it a Venn diagram of let's essentially cherry pick or just take all the best parts of these three different acronyms, which were all different from each other. They all emphasized different things, and let's just mash the whole thing together and create a new system that does address all the different things that all three systems were addressing. And that's where Hitman, our version of Hitman came from, with the sheep vomit mnemonic, which specifically gets into all the nursing care points of performance.
Yeah, we just saw that there was a deficiency and people were dropping the ball. We needed a checklist for people to walk through these nursing skills and not miss anything. And Hitman, so we took the Hitman from the SAS, which was hydration, infection tubes, medicines, analgesia, and nutrition, and we just realized it didn't work completely. So we changed H to head to toe, and then I and T remained the same. M is medications, A is admin. So we made that as far as our commo and resupply, things like that. And the N was nursing. And we just knew that within that N of nursing was A. ton of additional skills. And so this is what we were trying. So we have the Hitman, our modified Hitman, which I think is hit the ground running. I'm seeing it showing up everywhere now. So we had that Hitman, and I like Hitman because it works from, well, March, pause, Hitman. It rolls automatically into prolonged field care, along with our CABCDEFGH mnemonic. It automatically forces our medics to roll into prolonged care. So that worked perfectly. It was just that N was a problem. That nursing, you can't just say, oh yeah, go on, just do the nursing stuff, you'll be grand. We needed checklists. And so you and I I swear, Jason, we were not drinking tea. I'm telling you, we were drinking something a bit different than that. But I'm not gonna, I'm old and I don't remember things.
I was going to say coffee, but then I remembered we're in Europe where that's not as popular here as it is here in the States.
No, but I think the tea was called Chisk, if I remember right.
Yes.
Yeah, we were working together, and we were trying to come up with. I was trying to come up with a mnemonic that was risque to remember things on. I just couldn't quite make it work. And then late in the afternoon, you're like, "I've got it," and you told me the first. It was 2016, and you had brought your family over. You're living in Malta, and working for the college, and you you came off and you were like, "I've got it. It's sheep vomit," and I just couldn't believe my ears. I'm like, "How the okay? First, yuck. I mean, what? What? That's just disgusting." But how does this work? And you mapped it out. This is you, Jason. You mapped it out, and the checklist just works, and it makes people remember this now. So your brilliance is shining the light and making the world of austere medicine a little easier to see, mate.
Well, the only brilliance was just being a good Scrabble player that day. It was just a pile of letters. I mean, you and I literally cut out like little squares of paper, for things like elevate the head and exercise, passive range of motion, and vital signs. So we were just moving letters around, and then eventually, we sort of massage it into, well, sheep vomit. If we, I think we may have had something like passive range of motion might have been just that, and then we were like, okay, we've got sheep vomit, but there's two letter P, so we got to do something with that. So that's like, okay, well, they're exercises, which consists of putting the patient through passive range of motion. So we just made it work, and I'm happy that it does work and that it seems to have grown legs, and I hope we're getting some good patient outcomes with this.
So let's hear it from the horse's mouth, Jason. What is sheep vomit?
All right, so we have sheep vomit. This is looking at skin protection as the S. And when we think about protecting the skin, protecting the skin in a clinical setting is different than protecting the skin in the middle of, the Sahara Desert or the jungles of Burma. When you're outside of the clinical setting, then the things that can get on the skin other than, okay, the skin dried out and now there's chapped lips and things like this. Well, we're out in the sun possibly, so we want to make sure we're using sunscreen. We also want to make sure we don't have things like wasps getting into the wounds and ants and all those kinds of creatures that love just looking for easy meals and those kinds of places.
It's also, I mean, if you have defecation or urination and it stays on the skin, that's a problem. So I think S is also making sure that you tidy up what's going on what's on the skin. So you got, during your head to toe and Hitman, you hopefully did that you looked and you cleaned up the skin and stuff. But this S in sheep vomit is also just looking at every part of the skin, making sure it's clean. You can use shaving cream and a wet wipe to kind of scrub off dirt and blood, but you gotta keep the skin protected.
Yeah, absolutely. And what you just mentioned is much more in line with what a nurse working in a hospital would be definitely paying attention to. However, most of our students, as you're well aware, most of our students are not nurses, and I don't think any medical training I've been to previous to the last 15 or 20 years, I don't think anywhere was it mentioned, oh yeah, the patient urinated all over themselves, and we want to make sure that urine doesn't just sit on the skin and cause skin breakdown and stool on the skin and those kinds of things. So we have to emphasize that for our practitioners going into the field, having to do prolonged field care that are not nurses, where that kind of thing wouldn't be necessarily a very intuitive thing to do.
It's also, I mean, if you put tape on the skin every 24 hours, you need to take that tape off, put retape that line, of course, but somewhere else on the skin, so you don't have one part of the skin being under tape for long periods of time, because that's going to cause problems.
Yeah, so H is, we just kind of merged hypo and hyperthermia together. So I'm sure in your practice and as well as mine, most of the time, hyperthermia is not the issue unless you're in a very, very hot environment. Usually, our patients sort of default setting is they're too cold. So we want to, I mean, we could fill 100 podcasts just talking about hypothermia, obviously, but um, it's not only how do we warm up a patient in the field, which is much harder than it sounds, but how do we prevent hypothermia in the first place?
Yeah. And having the thermometer, so obviously core temperature is going to be best option, but in an austere environment, the only way to do that is rectally. And so if you don't have that option, we at the college we use thermometers under the arm, and we will use a wired. It's called a garden thermometer that has a long line and a metal bit that goes under the arm, and then we tape it there, and then that way we can always see the temperature without having to unwrap the burrito wrap to get access to the thermometer.
Yeah, exactly, and that's a perfect example of a diagnostic maneuver or a therapy making the patient worse in the process. Sort of an iatrogenic effect with that.
And it's just good to know that science, the evidence base is showing. There's several studies showing that the actual temperature is going to be zero point 0.6 degrees, zero point 0.6 C degrees uh, colder than core temperature. So core temperature will be about half a C warmer than what you have in the axilla.
Right. Yeah, and as you pointed out, that's going to be just from a feasibility standpoint a lot easier. I think I think saying, yeah, we're going to get a rectal temperature on every single patient, I think that looks good on paper. But in practice, in the field, that can be challenging.
I'm not going to unwrap my cold casualty and lift a leg and get a rectal temperature just to be that precise. He's now super cold, and I'm losing cool points.
Yeah, so yeah, exactly. We'll get the oral temperature or the axillary temperature and apply, what we call here in the States, a little Kentucky windage on that and get at least an approximation of the core temperature.
I think this H is in sheep vomit as people go through this checklist again and again and again. Is just making sure that your burrito wrap is wrapped, that you actually are getting results from this treatment, that they're at least no longer losing heat and hopefully gaining heat. So that's a big part of the H here in sheep vomit. So E.
So the first E is elevate the head. This is good practice to do, particularly with any head trauma, any incidents of increased intracranial pressure. We do need that head higher than the heart, and it also feeds into reducing gastric reflux. So stomach acid getting into the esophagus, and just overall patient comfort. I don't know anyone that lays in bed without a pillow, so think about your patient. Your patient's head should also be elevated to some extent because laying perfectly flat for an extended duration is just not comfortable.
As a psychologist, it's important to have the patient being rested, being relaxed, being non-agitated. And by elevating the head, they can now look around in the clinic that you're set up in this tent and become part of the group, so they can interact and they can have a bit of mental stimulation if possible, and it helps. It's a psychological benefit as well as a medical benefit of raising the head. So now they're no longer not engaged in the environment around them. Their head is up and hopefully up to 30 degrees, so they can look around and be part of the world.
Yeah, exactly. And it's also very very important when the patient's feeding or being fed that the head is up and we're not getting that reflux into the esophagus.
And then she'll even mention TBI and the need for the elevation of the head.
Yeah, that is part of our whether you're going with the CABC mnemonic or March or S March, there is definitely head injury considerations where if TBI is suspected or confirmed, we're taking steps to alleviate that.
One thing I like seeing our students do in Malta is that they'll get a chair from the room and they'll turn it upside down, put it on the stretcher, and then push it push the pillows up against it, and then that gets the patient up at a little over 30 degrees, but right around 30 degrees, and they're comfortable and they're not whinging, which makes my life easy. So it's a win-win. E. What's the second E?
So the second E is exercises, and we put in there parentheses passive range of motion. So we want to make sure that the patient's digits, limbs, and so forth, the ones that are able to be moved that are not fractured, that they're not getting stuck in a particular position. So we're not causing strictures in the hands or reducing range of motion that's going to turn into more rehabilitation down the road once they get out of the field and get to the hospital. We want to mitigate any long term effects of being stuck in a static position.
This includes getting them to walk if they can, of course.
Yes, walking is good exercise.
So what a lot of people forget about this exercise bit is the lymphatic system doesn't have any movement capability other than muscle movement. So the muscles moving in your body pushes the lymph, and that's helps with infection, and so you need to have your lymphatic system moving, and if you're just laying there, it's not moving at all, and then your white blood cells can't do what they're supposed to do, and this is really important for you to do exercise of the extremities and the whole body if you can, just to get the lymph system going.
That's true, and an added benefit of moving the legs in particular is you're helping get that blood mobilized out of the legs back into the central circulation.
Okay, P.
So the P is we do have two things here that are closely related. So this is pad the stretcher and also pressure points. So we're just making sure that we're thinking about things that again, this is not very commonly stressed in a lot of medical training where we run a scenario and someone gets dragged out of a building and onto the parking lot, and then they just lay there for like 30 minutes waiting for the evacuation, and no one's thinking about the fact of this person just laying on concrete and what that's doing to them, not only psychologically but also physically. So it's thinking about what are all the things touching the patient, right? And that goes back to skin protection, right? It's getting the wet clothes off them if their clothes are wet or otherwise soiled. What's touching the patient? Are they comfortable? And it obviously goes beyond comfort. If they are laying in a static position for too long, even if it's padded, you can get pressure sores. So that's the concept with this padding the stretcher and checking the pressure points. So the nurses figured out a long time ago where the problem areas are when you lay in a supine position. You've got the occiput and the scapula, the sacrum, the heels, the elbows, and things like that, where pressure sores tend to develop.
There's some really good journal articles on this that shows that within 30 minutes of a patient sitting in a difficult environment, ischemia starts. 30 minutes. They start having pressure point problems if you don't deal with it. So how would you so this guy has a pelvic fracture. Let's just make it really difficult for yourself. How are you going to move this guy to relieve the pressure points?
Yeah, that's a challenge, and I would think anyone with a pelvic fracture that needs to get moved. I hope the provider there has they have a good plan for pain management with that.
Definitely pain would be helpful. But even keeping him on the stretcher, somebody like a pelvic fracture, you just can't move. You can still lift the stretcher up, the whole stretcher up, off on one side and then the other, just to relieve a little bit of the pressure points. Do that every 30 minutes, and it'll help a bit.
Yep, yep, every bit helps.
All right, the big one, the V. What's the V in vomit?
So moving into the V, this is vital signs, which hopefully to our listeners is pretty self-explanatory. I think the nuance that we have to drive home with, our training that we do is how often are we getting these vital signs, and what do we make of those vital signs? Are we writing them down? Hopefully, they are being written down. Ideally side by side, where we can trend those vital signs and get a good look at what the patient's doing over the prolonged term. And we have definitely, we being the community, we've put urine output as one of our chief vital signs within this domain.
Yeah, trending is so important, and really should be tattooed on a medic. That the vital signs are great, but unless you get 3, 4, 5, 8 in a row, it's it's playing a guessing game. So you need to see that trending to be able to really assess whether you're winning this fight against death or not, and then documenting, of course. But we'll get to that as well. Oh, and vomit.
I was just going to mention one more thing on the vital signs. Yeah. So vital signs are vital, as the saying goes. And another one that I think is not stressed very much in a lot of the places I've trained is the core temperature. So core temperature in the setting of a trauma casualty, that's got me thinking about a couple things there. Number one, I want to make sure they're normal thermic, and then number two, in a prolonged field care setting, if the temperature starts to increase dramatically, then we're looking at the potential wound infection or sepsis or something along those lines. So that's one aspect of the core temperature. The other one for a non-trauma patient that needs to be stressed more is trending that core temperature and looking for any patterns, right? So is this a fever that's spiking every 12 hours, every 4 hours, once a day, once every 2 days? So there are many illnesses out there where they tend to have a distinctive fever pattern, and they're not necessarily pathognomonic, but it's just more information that we can feed into our diagnostic machine, if you will, and try to come up with a good working or otherwise confirmed clinical diagnosis.
Yeah, the elephant in the room is malaria, isn't it? So if you have certain types of malaria, you'll have different types of fever spikes.
Uh, yes, possibly if you have well synchronized populations of malaria blood parasites, that can be the case. Um, we we want to not rely on that necessarily, because you can have a multiple populations of parasites all kind of hatching, if you will, at the same or at different times. So your patient might look like they're just always febrile when it's actually just multiple parasite populations that are coming off the red blood cells.
And of course, it's the falciparum that's just random. They can be every 12 hours, 24 hours, 3 days, 5 days. They just like to play games, don't they?
Yep. Yeah. So the falciparum that can hit every other day. It can hit every day, or it can just be they can be febrile the whole time because you've got multiple parasite populations all going off at different times.
One other thing about the vital signs is we created the primary vital signs of CPRO. So capillary refill, pulse, respiratory, and oxygen. And we did that because it gives a very quick, almost immediate look at the patient's status. So just by putting a pulse oximeter on the finger, you get 4 of these vital signs that tells you about hemodynamic status of the casualty very quickly. So the CPRO is something that we are pretty aggressive with at the college.
Yep, as it should be.
Okay, so talk to us about O.
So the O in the vomit side of the acronym here, this stands for oral hygiene, and this is kind of in line with padding the stretcher and elevating the head, where not only is there a psychological benefit to the patient, there's also a practical clinical benefit that's tangible. So if we let the bacteria in someone's mouth just run rampant and that's not dealt with, they can start getting infected, and that infection can actually move down the esophagus and get into some other structures within the patient.
It was a huge light bulb moment for me in paramedic school when they said that the 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 bacteria that causes pneumonia is in your teeth, and you can't do anything about it. You just got to brush your teeth and knock the number of bacteria down so it doesn't cause a problem.
Yeah, it's just playing whack-a-mole basically, and that's what we do when we brush our teeth, when we wash our hands, when we take showers. We're just playing whack-a-mole. The bacteria are always going to come back no matter what we do, so we just try to keep it from spinning out of control.
So how would I clean someone's teeth who has a pelvic fracture and we can't really move him that easily at all?
So this goes in. So all these different interventions would fall in line with the precept of minimum, better, best, or good, better, best, if you will. Where okay, best case scenario, this patient can pull out their toothbrush and get some toothpaste on there and like brush their teeth normally, and floss their teeth. Like that would be the best case scenario. If we're in the middle of nowhere, no one has a toothbrush with them, and we're stuck in the jungle on the side of the road somewhere in the Congo, then we have to look at lesser means such as saline wrapped around the provider's clean finger with some saline on there. I'm sorry, gauze wrapped around the practitioner's finger, and just basically scrub the teeth off with saline as a kind of a minimum measure.
Or I can use a T-shirt, cut up their T-shirt, cut up a bit. It doesn't have to be sterile, does it? It has to be clean.
Exactly. Like no one's toothbrush is sterile either, so yeah, it just has to be clean.
Anything else on O?
I think that's it. Yeah, then moving down into the M is massage. So this is our DVT prophylactic measure. So deep vein thromboses can form, particularly in the deep veins of the legs, if anyone is kind of left in a very static position for an extended period of time, and there's no pressure on the limb such as you would have with like compression stockings and modern hospitals. In the absence of compression stockings, we're looking at just some light massage on the legs to make sure that the blood isn't just pooling and the calf muscles and so forth, and turning into a thrombus.
So this is good for the legs as well as the arms, and just getting that blood to move.
Yeah, I mean it's good anywhere. Yeah, like you're to your point earlier with the lymphatic fluid. So the body moving around is the body moving is good for circulation of the blood. It's good for circulation of the lymph, and again that goes back to, okay, this is good psychologically, and it's also good from a clinical therapy aspect as well. And the real or the biggest danger of the patient left in a static position is going to be classically it's the DVTs forming in the legs.
And always massage towards the heart, so you're moving that lymph in the direction it's supposed to go.
Yes. So the extent of the massage is, from my understanding, is the massage of the legs shouldn't be like a real vigorous, like this isn't, like a hardcore massage of the legs. Should be done gently. And one technique I've seen that seemed to meet that criteria is taking just a soft water bottle that's full and just running that up the leg, just like a little steamroller, just to get that blood moving.
Okay, moving on to eye in sheep vomit.
The eye in sheep vomit is ins and outs, right? And this is looking at what's coming in the body, what's coming out of the body, and what we're looking at there mainly is water, electrolytes, and food coming in, and then the outs is going to be your urine and your stool output.
And you definitely need to measure both of those.
Yeah, like I said earlier, the urine output is one of our primary vital signs in prolonged field care, and looking at the stool, it's a couple things. So it's like, okay, is this person defecating? That's the first thing. Number two, no pun intended, is what is the characteristic of the stool? Is there blood in it? Is there anything unusual? Does it contain a lot of fat? Is it watery? Is it hard? And we can use that as a gauge for determining if there's any kind of gastrointestinal disease or the overall hydration level of the patient. Are they getting enough fiber in their diet and things of that nature? And then thirdly, with the stool output is just recognizing that eventually this patient is going to have a bowel movement, and what's your plan when that happens? And so the plan needs to be to take care of the patient, to dispose of that, and make sure the patient's skin is clean, going back to the skin protection.
And that's a challenge. If you put a sand sling on this pelvic fracture, how to deal with that? It's a question that we get often in our courses, our prolonged field core courses in Malta and other places. And one option that I got from an old nurse that is that if you get a shirt, now definitely the patient's shirt or a bin bag, a trash bag for you Americans, you wrap it around your hand and you shove it as far up as you can. So as they defecate, you slowly pull out this bin bag or this t-shirt. And so the fecal matter doesn't pile up. You pull it out as it comes. So it makes less of a mess for you to tidy up.
Yeah. And then like I said, the other half of this equation with the output is the urine output. So very, very, very important vital sign. And we're looking at calculating our overall hydration level for our patient, mainly based on their urine output. And the blood pressure, of course, is also helpful, but the urine output is really the main thing here. So we have a formula for the urine output that we use, and beyond just calculating the volume, we also want to assess the urine. So how much is there? What color is it? Is there anything? Is there blood in the urine? Is it too dark? Is it too light? We can run a urine dipstick on it, which we should have in the field setting, ideally. There's that aspect, and then there's also sort of the nuts and bolts of, okay, how is this patient going to actually urinate? Again, this goes back to like minimum, better, best. So best case scenario is the patient is ambulatory. They can walk over to the side of the house or whatever and pee into a bottle. We can measure that, urine output and then dispose of it. And then going to the other end of the extreme there, okay, the patient is immobilized and, a pelvic traction or pelvic fracture splint, and they can't get up, or maybe the urethra is torn. So we're looking at, different modalities such as urinary catheters, suprapubic bladder taps as needed. And there's a whole, we in the past have spent, up to half a day just looking at different ways of just the mechanics of getting the urine out of the body safely.
That was one thing I really appreciated about DMI and listening to Dr. Hagman, is coming up with these options of urine catch and realizing that we we need to stand to pee, or be sitting down in the commode, and laying down and peeing is just not natural. It's difficult for so there's two sphincters that open up for all of us to pee. We have control of one of them, and that's the one that's just not going to let go unless we're standing up or at least upright. So trying to get someone to have a wee whilst they're laying down is a challenge.
Yeah, it's very difficult. It's if you've never had to do that, it's surprisingly difficult. I was, many years ago, I was immobilized to the point where I had to pee laying down, and we've all been conditioned from early childhood not to do that. So overcoming that conditioning is much harder than it sounds.
Yeah, it's something that uh, it would be good to have thought this through before we get to the point in a prolonged field care environment where we have to tackle this. I'm not saying that the listener should be going and laying around and trying this out on their own, but just think through this. How do you like do you roll over and have a wee, or it's something that there has to be an answer, and there should be options for you to think through this before you're dealing with this casualty in a stressful environment, and you're already stressed, and the environment mightn't be the best. Maybe it's cold, you're way up in minus 40. I've done ops in northern Canada, and not injured trying to have a wee is a challenge. How do you do that as a casualty? So these are things that you as a provider need to think about.
Absolutely, and this is why there's training. So there's nothing worse than being in one of these settings and then having to deal with a medical problem, even something as kind of benign sounding as, oh, the patient needs to urinate. And then all of a sudden that becomes this massive challenge that you had not previously considered. So we want ourselves, we want our students to have at least considered the possibility and have thought through. Even if you're not well equipped, you've at least thought about, okay, if this happens, then we're going to take this empty water bottle and have them urinate into that. But at least you've given it some consideration.
Yeah, it's better to think about it now and sort it out than it is to do it at 3 o'clock in the morning. So the last thing in sheep vomit is T. What is T?
So the last letter here is turn, cough, deep breath. And this is actually this is a direct carryover from my initial training at Fort Bragg in 1997. I do recall I wasn't able to find it here in uh, my medical notes from that era, but I distinctly remember the trainer that we had, who was a nurse. One of the things he really harped on, besides infection control and washing your hands and all this kind of stuff, was turn, cough, deep breath. So and whether or not that was part of our official curriculum, I don't recall, but I definitely recall this nurse really kind of beat us up and down on if your patient is immobilized for an extended duration, they're going to need to turn occasionally. You're going to want to have them cough. You're going to want to have them take a deep breath. The turning, well, the majority of this is for the pulmonary function, not letting the air and all of the detritus down in the lower lungs just sitting there festering. So it's just to kind of mobilize all of that. And the turning is also great for getting the patient off their pressure points and moving some of that blood around as well.
We don't realize that we do this ourselves on a daily basis. Like you get up in the morning and you stretch and like I'm struggling over to get my cup of coffee or tea going, and then you cough and you don't even remember you're doing this. So what's happening is your cilia has moved all of that junk up whilst you're sleeping, and your deep breath, your coughing is going to work the last bits of that out to where you can get rid of it. And if you're on your back as a casualty and you're not doing this, you're just going to have more and more gunk clogging up your respiratory tract because you're not getting it out.
Yeah, exactly. Hey, I was just going to say, I don't know if you've ever done this. If you Wikipedia search sheep vomit, it does come up.
And if you just do a Google search, it comes up a lot. And I've seen it on conferences I've never heard of by people I've never heard of that are mentioning this.
Yeah. So yeah, there's a pretty lengthy Wikipedia page on the page is called Prolonged Field Care. It's got the 12 core capabilities. It talks about ruck, truck, house, plane, and then core interventions. Says there's two acronyms: Hitman, coined by the UK military, and sheep vomit, created by the then dean of the College of Remote and Offshore Medicine.
Oh, Jason, yeah, they they need to put you up there. It's yourself that came up with it.
Yeah, well,
I was just in the room somewhat sober.
the first reference on the Wikipedia page is you and Tom Allenson.
Oh, that was our prolonged field care for UK paramedics.
Mm-hmm.
But no, the very first publication was in 2016 when I wrote about this on LinkedIn. I put it on LinkedIn as a discussion. So that's the original proof of sheep vomit was 2016, referencing our field guide, our pre first edition field guide that we made way back in 2015.
Yep. Yeah, there's you and Tom are the very first you're the very first reference
Aha.
on this. Oh, there I am. Reference number 22, and this is after Sean Keenan is covered in this. Yeah, so 22 says O'Kelly, Aebhric, Jarvis, Jason, and it's the Quorum Field Guide, second edition.
Oh, all right. So they reference the second edition. I'm all right with that.
Yep.
So you're on there. Notoriety here.
Nice.
The world knows that this came from the brain of a somewhat sober Jason Jarvis. You know what's interesting? It's been 10 years and we haven't improved on it. So it stands, I think. It's a pillar that stood its test at the moment. And like Hitman, we've finagled a bit and a bunch of other stuff. CABC, we've added E, F, G, and H, and probably get a Z in there eventually. And we've improved it, but no one has modified or completely changed sheep vomit. And you did this.
Well, we did it together. The interestingly here, so this is the Wikipedia page. So right after it says Hitman coined by the UK military, and then it lists like what Hitman stands for, and it's the Quorum version. It's not the British version. This Wikipedia, man, you got to look at it. Wikipedia.
Yeah. The Hereford guys coming after us then if we took their their thunder.
Uh,
But we may have to change that a
I
bit
don't think.
to give them kudos.
Yeah, I don't think they care.
So that is the sheep vomit. That is the origin of sheep vomit. It is completely and irrevocably the fault of one Jason Jarvis, and it is now there. It is law, nearly.
And we all stand on the shoulders of giants. So
Yeah. So this came about only because of the work from Dr. Hagman with TCCC and his concepts with DMI and OEMS, and we saw the Hitman from the SES. We saw the Ravines from the Prolonged Field Care Working Group, and we kind of amalgamated everything. And that sheep vomit is there in all its glory.
yeah, and I should amend that. We stand on the shoulders of giants, and also on the shoulders of previous casualties who have taught us these lessons.
Yeah. So my hope, Jason, in all fairness, and the reason I started the college is just for that. So we can get people, medics, docs, nurses, better trained to be better at the being the provider it's for the casualties, and it's for the community. What I hope more than anything else that our graduates goes out and makes the community they're in better because they're there, and hopefully will make a patient more comfortable, maybe cough a bit, have a urine output completely monitored and measured, all because of what you did, Jason, with creating sheep vomit.
Well, as they say, onwards and upwards, and I can't wait to see what we do next year.
Well, Jason, you are definitely a mover and shaker in the community. Your work in academia as well as in just training and standing in front of a class and making them learn these evidence-based skills. There's a little beam of light that hits you on the head as you walk around the world, mate. And I, for one, am proud to be your friend.
Likewise, Aebhric. I'm looking forward to what we do next, and the next thing right now looks like the 3rd edition Quorum Field Guide, which will certainly incorporate Hitman and sheep vomit.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.